Hi, everyone. We'll get started in just a few minutes. We still have everyone joining the room. The numbers keep going up. Well, hello and welcome to the Housing and Services Resource Center's webinar, Community Transitions, Creative Collaborations Move People Home. You are going to learn a lot from the presenters, and we've built in a variety of opportunities for you to be active participants too. Thank you so much for joining us. Next slide. My name is Lori Gerhard, and I'm the Director of the Office for Interagency Innovations at the Administration for Community Living, an operating division within the U.S. Department of Health and Human Services. I will be serving as the facilitator for today's webinar. It's a privilege to have so many of you here with us. Your active involvement in this webinar is essential for us to have an engaging discussion. Next slide. First, there's a few housekeeping items we want to address. This meeting is being recorded. By staying to participate, you are consenting to the recording. Also, all attendees have been muted for audio quality. One hallmark of our webinars is active participation from attendees. So please frequently use the chat to make comments and submit your questions anytime in the Q&A feature in the Zoom dashboard. Or you may email a question or comment to hsrc@acl.hhs.gov. We've reserved time to address your questions at the end of the presentations. You can also use the chat or email if you have a technical issue or comment for another attendee. Next slide. Before we start with the presentations, I'd like to tell you about the Hsrc, or HSRC, Housing and Services Resource Center, which is a partnership across the Administration for Community Living, or ACL, the Centers for Medicare and Medicaid Services, or CMS, the Substance Abuse and Mental Health Services Administration, or SAMHSA, the Centers for Disease Control and Prevention, or CDC, and the U.S. Department of Housing and Urban Development, or HUD, and the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services, or ASPE. We've come together to collaborate and use all of our collective technical assistance resources to best support states and communities. In every state and community, there are a number of entities and programs that help people access housing and supportive services. Sometimes these systems are working in partnership and in a coordinated fashion. However, often these systems work separately and apart from one another. This is challenging for the people we serve and the organizations that support them in both systems. Stronger collaboration between these systems would enable more older adults and people with disabilities and people experiencing homelessness to achieve housing stability, live with dignity and independence in the community, and avoid homelessness and costly institutional care. The Housing and Services Resource Center, or HSRC, provides technical assistance to cultivate cross-sector partnerships that bring together housing, homelessness services, aging and disability services, physical behavior, and mental health services. After the webinar, I hope you will look at the HSRC website at acl.gov/housing and services spelled out. At the end of the webinar, we'll share an email address so you can be in touch with us and get periodic updates too. Today, we'll hear about innovative programs and partnerships in Minnesota and Iowa that are working together to transition people out of institutions back to the community. Next slide. It's my distinct pleasure to introduce our first two speakers. With us today is Karen Britton, who is the manager of the Senior Linkage Line for the Minnesota Board of Aging. And joining Karen is Kathy Vondrum, who's the Senior Linkage Line Coordinator for the Minnesota Board on Aging. Karen, the floor is yours.
Thank you so much, Lori. It's really an honor to be here with you today. And we want to take just a little different approach about how we see, how we are trying to, with every conversation with people we serve, find out their needs and make sure that they know what's available in Minnesota to help them with whatever needs they need as they're all aging, and we're hoping aging well. And one of our biggest goals on every contact is how they can live well at home, how they can make those housing choices and provide the services they need so that those choices can be met. Next slide. So what might be unique about Minnesota is we have consolidated so many programs, both state and federal programs, to our partnerships with our area agencies on aging, but we call them the Senior Linkage Line services. And that incorporates many different federal and state services, such as pre-admission screening. We have return to community. We do our SHIP, our Medicare counseling. And then Minnesota also has a statute that requires us to do counseling for anyone that's going into assisted living to make sure that they understand that there might be other options to stay in their homes. So we look at all these different contexts as an opportunity to find out what their needs are and what programs might be helpful for them to be successful when they're living at home. Next slide. So as I kind of went over, we have all of these different programs housed within the Senior Linkage Line. And with those programs that they're all about, many of them, the first ones I'm highlighting, housing options. That's for everybody that is considering a move into assisted living. They actually have to get a verification code from us to sign a contract to make sure that they understand what assisted living is, what it isn't, and to talk with them about how their needs might change as they age and want to make sure that it's a good option for them. And then we have pre-admission screening for anybody, and both of these are regardless of age. I should say almost all our programs are, even though the majority of people are over 65, it's a service that's offered to everybody in Minnesota for most of these services. Pre-admission screening is to screen everybody that goes into a hospital, or excuse me, a skilled nursing facility in Minnesota is screened to make sure that their needs are met there. And if there's a concern that they have a higher level of care needed, it's referred to our county to do additional screening. And then return to community, which we're talking about today, is everybody that's leaving a skilled nursing facility, though there's many other ways that people can be referred to us to provide this service. And that includes hospitals, providers, or friends and family. So we have a way to find out the information of everybody from the Department of Health that's coming out of a nursing facility, so that we can contact them and offer, make sure that they have the help they need to move home. And then we add SHIP in here because Medicare counseling is definitely an area we find out, especially if they're having trouble affording Medicare Advantage programs or other programs. This is really a key place where we can connect with people to bring down their monthly costs in a variety of ways, or find out if they're struggling in home. So we use this as an opportunity as well when we do Medicare counseling. Next slide, please. And also even with Senior Medical Patrol, because we're out in the community with outreach programs, another opportunity to showcase the different ways that they can reduce their cost or find out more information on how to be in their home. And then we have the prescription drug assistance program within Minnesota to help them with drug costs as well. So all of these, we don't see them as, or we try, it's always a work in progress, not to be siloed, but to look at all of these different programs as an opportunity to find out all the different needs that they may have. Along with these, if we find a person that looks like they're eligible for other services, we do help them or direct them to fill out the information to apply for many of the programs. Mostly it's a one form that they have to fill out for Minnesota that links them to these other services. And so we try to lead people in that way if we know that financially they need some assistance. Okay, next slide. As I just said, we're very fortunate in Minnesota. It's a combination of state and federal funding for these programs. And what we really like is they really match each other. So when we have a gap in one program, Minnesota has been able to provide some of that information to link all these services together. Next slide. So the first point of contact for a lot of people is this counseling before they go into assisted living. And you can see we see 10 to 15,000 people we talk with on a given year as they're moving. And so it's really our first opportunity to connect with them, hopefully before they're in a crisis situation, to make sure that their move is something that they want to do and that they can afford to do, and give them alternatives to stay in their home if that's what they'd like to hear about. Okay, next slide. And again, when we go through the demographics in Minnesota, close to 97% of the people over 70 are white. But we know this is an issue that we have, that are we reaching the people that we need that are underserved? And so that's something we are continually challenged with, is finding out who's not calling, who doesn't know about our services. So that's one of our challenges. Okay, next slide. So pre-admission screening is our next point of contact, and that's where we have a lot of contact with people. That is something that we're provided from the state of all the names of the people and the contacts of people going into a nursing facility for that screening. So we don't talk to 67,000 people by all means. We process many of them, and we don't have a concern, but we talk with the hospitals and the nursing facilities and might find out more. And we certainly try to get in touch with people in the nursing facility to see if their stay there is acceptable and find out more about where they're going to be moving back to. And this is a key place where when we're working with our pre-admission screening specialist, understand that this seems like a problem that's at risk of not succeeding when they return to their home, they can contact their colleagues in the Return to Community group so that it continues that care without them having to be referred. Next slide. Pre-admission screening, again, this is a service not just for people over 65. It's for anybody that's going into a nursing facility. Next slide. So I'd like to move on to Return to Community, which is the main focus today. And our goal is to help people live in the least restrictive setting of their choice. And Minnesota does give us $8 million a year to provide this service. And we help an average of 2,000 people a year develop a plan. Now, that doesn't mean a lot of people we call seem perfectly capable. They have a good support network, but at least they know we're there, and we're able to help them if we can. And so that's why it seems like a small number, but there's a lot of follow-ups. Sometimes they follow up for 2 or 3 years after the fact. So even though it's 2,000 people, it's a lot more personal contacts, including going into their homes. And I'd like to turn this over to Kathy. Kathy, we're so happy that she joined our MBA staff, but she was a manager for the Return to Community in our Metropolitan Area Agency on Aging. So Kathy, can you just give a little flavor of what the Return to Community specialists do?
Absolutely. Thank you, Karen. During my time when I was doing the Return to Community work, I was actually a community living specialist for most of those years. And what we would do is go out and visit the client either in the nursing home, or we also started getting referrals of people who were living in their home and wanted to continue living in their home, but they needed resources and services to do that, and they just didn't know where to turn. The majority of our work was in a care center or a nursing home. And we would go out and visit with them. Sometimes they would want their families with them when they were visiting with us. And we would just talk about what we could do. And basically what we did was we would do an assessment, a person-centered assessment, and talk to them about what their needs were. What were their goals? What are the things that are important to them? And if their goal was to return to their home, whatever their home might be, whether it was a townhome or an apartment or a single family home, we would talk about what are the barriers, what things are keeping you from going home. Is it a ramp now because you had a stroke and you need a wheelchair? Maybe they needed Meals on Wheels or something like that. So we would do that assessment. We would help them, work with them. And the social worker, it was very important to have a good relationship and work in collaboration with the social workers at the care centers, because they were the discharge planners. And we would work with them developing a support plan of the resources that we felt might be helpful for them, whether it's a lifeline type button in case they fell, or like I gave the example of a ramp or something like that. And then another, we would walk through with them their discharge home. But like Karen described earlier, a really big important part of it was that we would follow up with people once they were home. So we had a follow-up shortly after they got home, just to make sure that their home care showed up or that they had their medications. And we had a list of things that we would go through and just make sure that that transition going home was going well. And then we would offer, if they wanted, again, staying with that person-centered focus, if they wanted to, we continue to follow up with them periodically, just checking in to make sure that they were still doing okay. Or if they developed different needs, we would help them get linked with new resources. So like Karen said, we had some people that would continue following up with us just for a short time. And we also had people that followed up with us for about 5 years. That's about it. Yeah.
Thank you, Kathy. I'm just checking chats, and I see a chat from Alan about why are you using the term least restrictive setting from special education rather than preferred term of most integrated setting from the ADA and the Olmsted Supreme Court decision. Very different legal and operation constructs. Yep, thank you very much for pointing out. I think that's a great turn that makes a lot more sense. So I appreciate turning that out. I think I've probably borrowed slides from earlier ones, and that's a good catch. Thank you. Next slide. So again, return to community is certainly a population as we see people leaving nursing facilities. On the older trend, 75 and plus is the majority of them, but we still have quite a few people that are 60. The under 60, that is because it could be a couple, it could be for other reasons that we're helping them or caregivers. So that's why there is some people that are less than 60. Okay, next slide. And again, the gender pretty much stays the same with almost all our demographics. Okay, next slide. This one, so one of the questions that was asked when we were talking about this presentation is how do people get referred? And if you can see at the very bottom, the majority of our referrals is through our Department of Health, provides a list to us on every Tuesday of people that will be departing. And I can't remember, Kathy, where they are in the nursing facility of when they're going to depart, what the time frame is, but they provide a list to us that we curate and distribute across the AAAs to review them and make contacts with people. Kathy, is there any time,
the list was of people who had been in the nursing home for 35 days.
That's what it is. Thank you. I knew there was a reason. But you can also see that we get a lot of direct referrals from nursing facilities. Previously, they might know our services and ask for support from friends, family, clinics, doctors. So we'll take referrals, and we have an online site that anyone can make a referral for assistance. A lot of times we'll vet the call through our senior linkage line regular INA service, but then they would refer them to the return to community team. So we get a lot of referrals from different areas. Next slide. And I just wanted to point out the great partnership we have with our area agencies on aging across the state. And as we say, this is an in-person service a lot of times. They also have keep connection and rapport with hospitals, nursing facilities, assisted living, to make sure that we're not a threatening presence. We're there to partner with them across the state. So that's why we feel, even though it's a statewide service, we really try to have those personal connections in the community to make people feel trusted that they can contact us to help them. Next slide. And just some of our goals. One of the things we really struggle with, well, I just can't give the agencies, our area agencies, enough credit for during COVID, when this was an in-person service. And what do? We went virtual. They did like Zoom type calls. They did other ways, did a lot more reassurance on the phone, maybe called people more. And they've really turned it upside down to realize that there are people that would prefer to talk over the phone or do a teleconference because they don't feel comfortable, especially with COVID and other reasons, of having someone come into their home, even though, and a lot of times that's the best place to evaluate their situation. We're respectful for that privacy and feel like we can serve more people. And as you can see, Minnesota is a very large state, lots of distance. So we can certainly serve more people if some of the people prefer virtual, just from the amount of time it takes to drive to very remote communities and people that live in rural areas. We also are just really concerned about isolated seniors is definitely one of the main issues. We think we need to have more online service options. We're a Monday through Friday call center that doesn't always serve the needs of people when they're transitioning, and really understand outreach to underserved populations. We're blessed with having 11 tribal nations in our state, and working with them in unique ways and partnering with them is another one of our goals so that we can assist them as well. And I believe that's the end of my slides. I'm looking at the chats to see if we have a question. What about services with disabilities under age 65? Oh, thanks for asking that. I meant to mention that we have some very clear or close partnerships with what in Minnesota is called the Disability Hub. And then we have a Vets Link that we have. And then we have the group that is our Money Follows People services, which is we call Moving Home Minnesota. And so when we're working with people and we identify those special needs, we don't want to ever just tell them to call one of those entities. We try to do the calling. We might do a warm transfer. We work with them to see if there's additional services or better services for them depending on their needs. Do you work with the SILs in Minnesota? The SILs, we call it the Disability Hub. So they have the phone system, and we work with them pretty much on a daily basis. Because we are the Medicare SHIP counselors for the state, they transfer all the Medicare calls to us. And then, so we have a very close rapport with the SILs in more of a referral. And when I say referral, definitely a warm transfer. We work very closely with them, so we know what service, so we can provide both services and don't have to be the experts. And the same with the Vet Link or our the Veterans Administrations in their local counties. We work very closely with them to make sure that we can look at all the different services. Let's see. Use of Money Follows the Person. That is not something that's within the senior linkage line. We do not get money from them, but our partners in Moving Home Minnesota. So once someone applies for assistance in Minnesota, and we have another service called Elderly Waiver, once they apply for that, then the Money Follows People would apply. They'd be ability to have all those services once they go through that channel. So we don't give them anything directly, but we assist them to get signed up for those programs. And then that team would be taking over in partnership with their care coordinators. Are these programs available in all states? I will leave that to Lori or one of the other board panelists. How did all your services get consolidated under one agency? I'm not as familiar with the history. I know it was a long process to try to get over many years of trying to it. For instance, pre-admission screening used to be done by our counties. And then there was value to say, to make sure that initial screening was done by our team. So it's kind of evolved as the senior linkage line has grown a reputation to bring on more stuff. And it was just from an administrative process too, much easier to have it all in one area to train them because so many of those programs overlap. So it definitely was over time.
Karen, this is Lori. I was going to maybe jump in. We're going to take some more questions. But I want to thank you. We're going to take more questions later. So everybody stay tuned in. And if you have more questions too, put them in the Q&A because Karen and Kathy are going to be back with us after we get a chance to maybe do a quick poll with all of you and then hear from our team from Iowa. So Karen and Kathy, thank you so much too for that overview of the Minnesota Board on Aging's return to community and related programs. It's really great to hear how it's getting more in how things are integrated within your state. So before we introduce our Iowa panelists, we'd like to hear from all of you. And we'd like to know about how you might be involved in transitions back to the community. So in the sidebar, you should see a Zoom poll. And it's popping up right now. Our question is, how would you describe your organization's current role in supporting individuals who are transitioning to the community? And please choose one of these options. Actively support, provide occasional support, do not currently provide support, but maybe in the future, not applicable. The poll is really for anyone that might be helping people transition out of institutions and people of any age. Thanks for that question. And Maya, I'll look to you to give us a signal when some people can't see the poll. It should be on your sidebar. It might have popped up in another window. Okay. And Maya, do we have the results of the poll? Thank you. So it looks like 65% of you responded that you actively support transitions. 20% indicated provide occasional support. 6% are not currently providing support, but might in the future. And 10% indicated it's not applicable. Okay, so it looks like many of you are already engaged in this work. So thank you for that. And those of you who are somewhat engaged, thank you. And those that are interested to maybe get engaged, we thank you for that interest too. And let's see here. We're going to be sending out the slides and links after the webinar. And I just want to remind everybody again to share your questions in the Q&A. And in the chat, could you include what you and a key partner might be doing to currently support transitions? Okay, great. We're getting some responses. Healthcare Access Maryland is working with some partners. This information is really helpful to us. It helps us see where there might be partnerships that we could look to, just like we have with Minnesota and Iowa today, to maybe share your stories with others. You know, it's the work you all do in your communities and states that really enable us to see different ways we can be working together across these sectors to really support the same people. So thank you all for sharing. I'm seeing lots of responses come in. This is really, really helpful. We'll keep the responses coming. Maybe we could move on to the next slide. So at a neighboring state, Iowa, they decided to replicate parts of the Minnesota Return to Community approach. And I saw in the chat too, some of you were like, does our state have this? Could we do this too? Well, you're going to get to hear firsthand from Kent Ohms, who is the Community Living Director for the Iowa Department on Aging, on how they went about replicating components of Return to Community. And after Kent gives you an overview of the pilot program, he's going to be joined by two more Hawkeyes, Sherry McDonald, who is the Lifelong Director of Connections Area Agency on Aging, and Robin Shaver, who is the Director of the Care Management for Methodist Jenny Edmondson Hospital. Kent, the floor is yours.
Thank you very much, Lori. Give me 1 second, sorry. So yes, hi everybody, I'm Ken Ohms, and we started the Iowa Return to Community Initiative after kind of finding out quite a bit about the Minnesota's Return to Community Initiative. So the name similarity is not a coincidence. And I'm just gonna kind of walk you through the few parts of what we've done. So next slide, please. So for our Return to Community Initiative goals, this is focused on non-Medicaid consumers for our pilot. You know, Medicaid consumers, we do have Money Follows a Person here in Iowa. I think I saw somebody in the chat mention that it is focused primarily on brain injury and developmental disability consumers. We also have an elderly waiver, which, you know, kind of covers a lot of the similar services as well. And so what we kind of wanted to do was to help seniors maintain their independence by keeping them in their homes with wraparound and supportive services. And really the initiative is about finding the consumers at their most vulnerable point instead of waiting for that phone call. So we focused on skilled nursing facilities for at least 30 days for the care transitions, but we also started working with a lot of the hospitals to start identifying consumers who would be coming and returning to their homes in some ambulatory sensitive conditions during those times. And to that point, you know, especially when COVID kind of came around and our first 1 or 2 pilots were up and going, and there were concerns from, you know, people not wanting to go into care facilities, the Return to Community Initiative really was a strong partner and option in working with that. Next slide, please. So overall, the Return to Community Initiative's goal is to reduce unnecessary facility placement and reduce unnecessary hospital admissions and readmissions and emergency department use. One statistic about Iowa is that we're actually the 4th highest state in the number of low care nursing need residents living in nursing facilities. So there's a lot of people that can be served in community settings if they just kind of would know about the services and have that connection and coordination for them. Next slide. So the key elements are much like Minnesota's program as well. We have the service coordination at discharge with the home visit for the consumer, usually trying to get to that home, you know, within, you know, a couple of days of getting there. During that, you know, March 2020 through, you know, that summer and fall stretch prior to vaccines picking up, you know, there had to be a lot of creativity with phone calls, with meeting, you know, maybe just at the door or window and talking to people, with the use of gram pads and other virtual communication devices. We provide up to 90 days of intensive services for them based on kind of their needs and preferences through the person-centered planning. A lot of it is transportation to follow-up appointments. There's also, you know, personal care and homemaker needs for a while, and certainly some nutrition. And after that, and then at the end point of 90 days, you know, a lot of times either the senior is kind of like stabilized and back to their, you know, level of living in the community successfully, or they might discharge into our Older Americans Act case management services. Next slide, please. So currently, like we kind of said, we're still at a pilot funding stage and not statewide yet. We have 5 out of our 6 local area agencies on aging participating in return to community. We've built out a lot of different partnerships with the hospitals, skilled nursing facilities, and we're also looking even at moving a little bit further upstream at seniors identified with needs in a clinic setting who maybe are at risk of being hospitalized or going into a nursing facility, but haven't actually had that inpatient stay yet. The funding right now is just pilot funding from the Iowa General Assembly. And we're kind of, as we build this out, just trying to find that future direction and right point of this, figuring out how it can fit into, hospital and ACO value purchasing models, or, if there's potential for, Medicaid 1115 waiver, just kind of a lot of options out there. So that's the end of the return to community introduction for Iowa. I saw a question come by, just how are AAAs funded in Iowa? There's the Older Americans Act funding that comes down federally through ACL that is allocated by formula based on populations and the number of people living in poverty and kind of some base block amounts. We also have what are called elderly services dollars, which is essentially the state matching funding that we get from the General Assembly that's appropriated on an annual basis and is also allocated by formula.
Oh, thank you, Kent, for that presentation. And I guess we would like to maybe start to answer respond to some of the questions that we've got. And so I'm going to ask all of our panelists to come back. And maybe we could start with a question for Minnesota. How have nursing homes and assisted living communities been involved in the design and implementation of return to community? Karen, we can't hear you. If you could maybe,
Thank
there you go.
Sorry about that. This program has been in Minnesota for a very quite a long time, and I think a lot of it was started more from a statute perspective than anything else. We had these statutes about counseling people before they go. It used to be housing with services, and now we finally have licensed assisted living, and the fact that we're part of, even though we're not part of the Department of Health, we're part of the state services, and so that we can share this information freely within Minnesota, and we can share it with Disability Hub so that we can try to break down those barriers between them. They were definitely involved in the design phase and before it went to legislation. So there were listening groups, those type of things. The one thing the AAAs do now really well is they visit hospitals and nursing facilities to keep that line of communication, understand the needs, partner with care coordinators, not only at those facilities, but also with insurance companies that have that role as well. So I'm not sure of the original ones, but I know they were stakeholders, and it was quite, I won't say it was an easy path. If I read through some of the history, it was before my time. I mean, it's a struggle to bring them in, but I think it's been very effective because one of the key things they do is to continue to dialogue with those people. And Kathy, I don't know if there's anything else in particular you all did to work with nursing facilities to make them work better with you during those transitions, or did they seem to be, they really appreciated the help?
I think you're right, Karen. It was a lot of discussions, and sometimes there was a little bit, they weren't quite sure what we were doing, and we had to really collaborate, not take over the job of the social workers at the nursing homes, but just be there to help support the transition for the person, the resident in the nursing home. And just, it took a while to develop relationships, but definitely we're able to.
Thank you, Karen and Kathy. We know that there really needs to be strong partnerships across the healthcare sector, the nursing homes, the hospitals, and the Disability and Aging Network, the housing sector. I'd like to turn to Iowa right now and ask Kent and Sherry and Robin, can you talk a little bit about the partnership in Iowa and how you're working with hospitals?
Well, we had, prior to going to IRTC, we had a hospital relationship with a local community hospital that Robin is at, Methodist Jenny Ed. So that was a great start for us. We just started adding the IRTC piece to what we were already doing. And then we reached out to other hospitals in the areas that we were able to staff and provide the service for. And then added on our SNFs as we went forward. Robin, I don't know if you have something more you'd like to add with that.
Sure, thanks, Sherry. We have, of course, are always focused on that, reducing readmissions and even ED utilization, which can be very costly. We know that housing insecurity and other health disparity or social determinants of health, affect access. And so we have a very close working relationship with Connections. And often those referrals, we utilize a referral platform for health services and social services in the community. We make those referrals straight to Connections, and then they can reach out to the patient once they're back in the community. We have, somebody posted a question about return on investment, and from our perspective, looking at it from a healthcare standpoint, the return on investment is clear when we, again, reduce those readmissions and hospitalizations. We've got several success stories, and that is directly due to those connections that Sherry's organization makes with the patients after they leave here in the community. We also work pretty closely with our community health center for low or no income individuals, and they often have those social services or care coordinators that can do the outreach to those patients and families once they're back into the community. So that we again really appreciate that relationship, and it takes diligence, but it can be done, and it can be done successfully. And I know our patients and their families really, really appreciate that.
Oh, go ahead, Sherry.
I was just going to say, to answer some of the questions that are coming up in the Q&A, with our relationship with the hospital and the SNFs, we try to get our coaches in there sooner before they are discharged. So the social workers or case managers at the hospital start talking with them about their needs for a home. And then we are able to get a lot of those things to them so that when they discharge from home or they discharge from a SNF or the ED, we can get a toilet riser or grab bars, handheld shower head. We can get those things out to them in pretty short notice. We've noticed too, like everyone else, the shortage of staff. And so we've incorporated a rapid response worker through our agency as a new program. And that's frequently the individual that will make those visits initially just to drop off equipment after a coach has talked to the people and found out what they need. So that's one way we've been able to work through some of that shortage.
That's real helpful. And when Sherry says SNF, she's talking about the skilled nursing facilities.
Sorry.
That's okay. That's all right. And so I know there was interest from a lot of states too. And how can we replicate the return to community initiative? So if so Kent and Sherry and Robin, if you had to offer one piece of advice on how to do it, what would be a key strategy people should think about or consider if their state currently doesn't have a program similar to Return to Community?
I'll just kind of start with something right off the top, and this is almost verbatim how one of the other AAAs in Iowa got started, but it was get your executive director out, into the community at the Rotary meetings, talking to the people. I mean, that was the moment that the executive director bumped into the hospital president, and the hospital president was talking about the problems that they were having with readmissions and seeing things from people. And, she was able to say, I'm the agency that solves that problem for you. And so, it's just about making the meetings and having the coffee to start the conversations and learn who is running the different agencies really locally within your area. Iowa was kind of different from Minnesota in that we've really kind of started at a local pilot level of, just agency to agency, whereas Minnesota was a little bit more built in at the higher level structure with, PASSR and those like automatic referrals at a systems level. So they kind of started at the top and work down, and we're working our way backwards up from the bottom.
The other thing I would suggest is getting to know the partners in your community. I thought I knew them. And when we first started our transition program with Jenny and pulled other community partners in, I was amazed at how many I did not know. And so developing those relationships with the nursing homes, with the assisted livings, with the clinics, with the food pantries, the housing authorities, those are all beneficial relationships as we go forward with the transitions.
And I would add that our health system is very fortunate to belong to a post-acute care collaborative involving Nebraska and Iowa skilled nursing facilities. There's about 25 of those. And we work very closely with those facilities. It truly is a partnership. And you get to know everybody, you understand what services they can and cannot provide. And it really helps that transition of care, not just from the hospital to the facility, but also from the facility and getting the patient, or that person back home, or some longer term, care options.
These are great suggestions. And Karen and Kathleen, I'd like to bring you into this conversation too. Like, if you were talking with a state or partners in another place, across the country, what advice would you give them, or what would you tell them to try first if they wanted to develop a program like Return to Community?
Kathy, you can jump in too if you have any questions. I think what's really valuable is trying to ask those questions at earlier from a crisis point. I mean, I find that the most valuable. That is, I'm sure you all have an information and assistance and way that older adults come back to you and really find out within the communities what kind of what's the need and what kind of programs are already out there to help them. And for us, partnering with the SILs, the Disability Hub, the VetLink, trying to really look at that network of different services, because we've learned so much from them on how we can support people better. That's it. Another one, I think there was a question there about how do we reach underserved populations? And, we've been really working hard on finding those trusted partners in the community in our we have a really diverse communities, and finding out from them first what they need, not what there is. One of the big things we found, working with some cultures within Minnesota is if we said to bring in help, that they should bring in chore service, that would be really offensive in their community, that their family's not doing what they need to do to take care of their family. So that's another thing we're trying to be really sensitive and partnering with the people that understand that culture, and their needs might be completely different than other cultures. I don't know, Kathy, if you had anything else to add of what you found successful in building that.
I think the question of how do you start this is a really good question. I feel very fortunate to be in Minnesota, where the state, funding is always an issue. So the state has funding, like Kent was saying, we have state at the state level already. And I didn't have to go out and find a funder to fund my program. I was very fortunate to have the state of Minnesota that funded our program. So I think that's very important. I think, like you all have already said, partnering with all the people that know that this is an important service, and the people that, the hospitals and the nursing homes and community centers. The other thing I agree with Kent when he was talking about, trying to do this a little bit more upstream. I would love to see us really connecting with clinics, because I do think that doctors and nurses at the clinics can identify people that maybe we can get services in a home before somebody falls and breaks their hip and then they have to go to the hospital and the nursing home. So it's making those connections with people, letting them know that there is value in this, so that you can get the funding you need to start.
Kathy, just as an interesting piece on that. So when we got the money for Return to Community, it wasn't some altruistic, like we need to help older adults. It was really to combat, there were studies from the University of Minnesota about how can we reduce spend down, that people were going into assisted living. They had no idea how expensive. And then they would kind of become wards of the state because it spent down so quickly. So the way that it passed in our legislature was more of reducing taxes to support people if they spend down so quickly. So it's kind of an interesting bent on why it came to be.
This is really helpful information. I think people are getting some great ideas too about how they might be able to get started in their state. There are some questions too around, let's see here. How long do you provide case management services? And that's for both Minnesota and the Iowa team.
Well, I can answer for Iowa. We do pretty much a 30-day, fairly intense program with a coach. And then our hope or goal is at the end of the 30 days, we've connected them with the resources that they need, gotten them the equipment that they need, helped provide a stable transportation program if needed. And then we do monthly phone calls at 30, 60, and 90 days post that original 30 days. We do have people who aren't stable at the end of 30 days, so we will carry them forward with the services that they continue to need until we can get them connected. And sometimes they do go into case management with our area agency for ongoing service and assistance.
So I can talk about it from the Minnesota standpoint. We never referred to ours as case management services. That always had kind of a different connotation to us. It's very intense. And especially I live in the metro area near St. Paul and Minneapolis, and the amount of people that we helped in that area was very large. So in order to be a case manager, your caseload would become too large very quickly. But having said that, is very similar to what Sherry was saying. We would go out and see them soon after they would discharge from the nursing home. And they always had our phone number that they could call if something came up. But we would check in with them shortly after, and then about maybe 14 days later, we would check in with them. Again, they could call us if anything came up in between times. And we did a very similar thing, the 30, 60, 90 day checkups with them. Again, that's us reaching out to them, but they could always call us if something came up. And then, like I said, it kind of spread out over time. So I view case management services a little bit differently than what we did in Minnesota, because those case managers are very, very involved. But it is similar to how Sherry described also.
This is really helpful. And I know we're at a time where we got to it's 2:55 and we're going to stay true to time so people can commit to their 3 o'clocks. But I want to tell you all that we have 24 open questions yet from the group, and there's probably several in the chat that we haven't gotten to. So I'd like to just quickly ask that, maybe we could, after the webinar today, share these questions and see if there's some answers we can maybe provide in writing to people. just so that you all get the benefit of the great work of Minnesota and Iowa. This has really been fabulous, what you all have been providing to us today. And I know a lot of people are interested in your experiences and your strategies, and we appreciate you sharing them. So we're going to move on. And if we can go to the next slide. I just thanked the Minnesota and Iowa speakers, but I want to thank them again. And if you all are able to use the reactions button to just show your appreciation and give them a little applause, that would really be great. We really do appreciate Karen, Kathy, Kent, Sherry, and Robin, all of your work in preparing for today, your leadership in developing state-funded transition programs, return to community, the strategies that you've shared. We hope everyone has gained an initial understanding of core elements of these programs and also the critical partnerships, working with the community health centers, the idea of a rapid response worker, partnerships with hospitals and nursing homes, the post-acute care collaborative in Iowa and Nebraska, connecting with clinics and primary care physicians' offices. Really great partnerships we heard today. All of us have heard opportunities we can act on in the coming weeks. After this webinar, we'll send you the slides and we'll post the recordings later in August. Another resource for your work is the ACL website for care transitions programs. Staff will put the link in the chat so that we hope that you'll visit that and take a look at it. It's really been amazing, the work that the Disability and Aging Networks have been able to do in transitioning people out of institutions back to the community. You can also send the ACL Care Transitions team an email, which staff will put that email address in the chat. If we go on to the next slide, before we close, there's a couple things I want to make sure you hear. One is I want to remind everyone that in the coming days, we'll post the recordings of the webinar and the slides on the Hsrc website. In the meantime, please keep using the site, which staff is providing in the chat. We do post resources there on a regular basis as announcements come out from the organizations that the federal agencies that are supporting the Housing and Services Resource Center. If we move on to the next slide, I want to call your attention to two really exciting webinars that are coming up on August 22nd from 2 to 3 p.m. Eastern Time. We'll be featuring the Working Together to Empower Community Inclusion. Community inclusion is so vital and important to housing stability. Moving people out of the transition without community inclusion really sometimes doesn't work in a way that enables ongoing housing stability. And we know there's several factors that go into housing stability, but community inclusion is a key one. We're going to, on August 22nd, we're going to get to hear from a team in North Carolina that includes a Center for Independent Living, a health plan, some seasoned professionals that have been working in this space for a long time, and they're going to share some stories, their strategies and tips on how they really help not only transition people back to their homes, but help them live and be vital members of the community and really engaged. So tune in and watch for information to register for that webinar. And then the second one that is really exciting too is on August 29th, if we can go back a slide, from 3 to 4 p.m. Eastern Time, the Continuums of Care. The Homeless Network has been developing continuums of care for several years, since like the 70s. And we really want to be sure we can start to bring together the aging and disability networks and the continuums of care to really create more of an integrated infrastructure or network across the country to really help create more stable housing, help people stay stably housed, get the services they need, and be able to live in the community. You'll receive information about this webinar too. If we go on to the next slide. Please complete this short feedback form for SurveyMonkey. It's really helpful to hear from you on how we can really design these webinars to provide the information you're looking for. And we want to hear from you because we always look at that and we try to make improvements as we go forward. We want to hear from you. Please email us at hsrc@acl.hhs.gov If you have anything that you'd like, or if there's information that you're seeking, we're here to help you. And finally, we want to thank Mission Analytics, US Aging, Jessica, our ACL interpreter, Karen, our CART specialist, Alicia Anderson at ACL, who leads the Housing and Services Resource Center on the federal side, Caroline Ryan, who leads our transitions work, and all our other partners, and for their roles in producing today's webinar, especially our speakers. And we're especially grateful for all of you who joined us today. It's the participation, the information we share amongst ourselves that really strengthens our opportunities to really respond to the people we serve. So thank you so much and have a great afternoon.